Hello. 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 I seem to be audible, but the camera is not coming on. Okay. All right. So let's start. You've already started this week with the demonstration of the dissected specimens in support of the practical syllabus for your abdomen and pelvis part of gross anatomy. Now, ideally, we should do the dissection and video record it, but this little camera doesn't support that. And yesterday, I tried to do it in our dissection lab, but it wasn't very satisfactory. So what I've got today is basically a series of clippings, screenshots, still pictures of how it goes. Try to understand it well and try to correlate with a gross anatomy atlas if you have it. If you have it already, probably you should bring it and keep it open to the corresponding page. Otherwise, after this class is over, you try to revise the same thing with visuals from a gross anatomy atlas, because there it will be labeled. I haven't labeled much here. So there it will be labeled. It will be a quick revision for you because the theory class on appendix secum colon is all over. So it will help you correlate with the theory part of it and what the visual looks like. Because this, what today's class is supposed to help you answer the practical and viva and to score in it. So I'll just highlight those points which are essentially required in the practical, but the Viva can go anywhere. If you're answering well, it can go deeper. But at least the bare minimum what you have to be able to identify and show will do today. So when you are doing a demo in a dissected cadaver, this is a pubic symphysis. All right, this is the lower limb. This is the flap. This is the anterior abdominal wall flap, and this is another flap, the cuttage. And these are the loops of intestine underneath. But just when you cut and reflect the anterior abdominal wall like that, the first thing you see is the greater omentum just underneath the peritoneum, and beneath it will be loops of small intestine. Kind courtesy, Dr. Akram Jafar. I've seen this, I've taken these sources from 4 or 5 web sources, 2 or 3 YouTube videos, and 1 or 2 websites. You can look for this. It's not very comprehensive, but it's a quick revision of what you need. So I think he's based at Sharjah or someplace, and he's probably Egyptian or something from his accent. But the point is that anatomy is the same everywhere. So what you will see first is an apron of mesentery loosely hanging, which has a free edge like that, which will be covering all the loops of intestine just as soon as you open the peritoneal cavity from the anterior side. When you lift that, then you will see the next layer, which is these small intestine loops underneath of the omentum. This is, I think his name is Dr. Sam Weber, SAMWEBER, and he only did this demo on a plastic model, where he also had one layer of omentum which he removed, and then he had this layer of small intestinal loops which he has removed to reveal that you have the retroperitoneal structures there. This is the descending colon becoming sigmoid. This is the ascending colon, and right behind this will be the cecum here and an appendix on the abdominal wall. So he's taken it out. He's taken it out of the abdominal cavity as a piece because it's a plastic model. We will do a dissection and remove the small intestine loops. So this is your duodenum. So we'll come to the end of the duodenum somewhere there, cut it off, then take jejunum, ileum out together, leaving a small bit down with the cecum. So the terminal part of the ileum, the entire cecum, the appendix attached to it, and the ascending colon will be left behind. The ascending colon will be like this, and it will come till here. They've also removed the transverse colon because that is the intraperitoneal part of the large intestine. The pancreas is here, and it has been dissected to show its internal duct. The spleen is here. Right? I assume these two are adrenal. I don't know what they are. I don't know what this is. This could be an adrenal. I'm not sure. This is the esophagus going through the diaphragm, and this is the underside of the arch, the muscular thoracoabdominal diaphragm. So esophagus termination is there. Whole stomach is not there. Duodenum is there. Jejunum, ileum have been removed. Cecum, appendix and ascending colon will be there. Transverse colon has been removed. Descending colon is there. Sigmoid has probably been removed. I don't know. We will see. But this is how we show it in a plastic model. It's simplistic in one sense. It is childish, but it is a necessary concept for you to have because you haven't done the dissection yet. That there is a layer by layer. There's a anterior or superficial, and then deeper structures. So after we remove the small loops of intestine, if you're doing it in the abdominal body in a dissected cadaver, you will see that this is the ascending colon with all these yellow pieces on it. These are the appendices of Piploicae. Transverse colon more or less been removed. This we can't make out exactly what it is. This I've oriented it like this, though we will be examining it. Actually, we'll be standing here and we'll be on the right side and we'll be looking at it sideways. I'll show you that view also. But this is to show you the midline structure, the abdominal aorta dividing into the common iliacs, and this blue one is the inferior vena cava. So this is the midline structures along the posterior abdominal wall, and on the right side and the left side will be the two vertical intestinal pieces. So this one will be ending in a dilated, a wide portion called the cecum. Now this looks a bit messy. Not very sure which part is, where is the outline and where is the thing. Don't worry about it. This is supposed to be the cecum, and the vermiform appendix will be attached to the cecum, and this white cylindrical finger-like process is a vermiform appendix. And this one is posteromedial to the cecum. It is attached to the posteromedial cecal wall almost always, and it can be taking any of the o'clock positions. It can have a 12 o'clock position. This is more or less a 2 o'clock position, which is pointing towards a splenic position, but it's a short one. Or it can have a ileal position. The small intestine will be ending somewhere here. It can have a pre-ileal or a post-ileal position, but it will be roughly 4 o'clock or 5 o'clock position. Or it can have a straight down position, or it can have a lateral position, or it can have a 10 o'clock. So, and it could be anywhere, and depending on how it is situated in that particular person, if it is inflamed, if there is an appendicitis, the symptoms in the patient will vary. They can vary, and the patient's first primary problem, difficulty may be different depending on how long the appendix is and what its position is in that particular person. So first you need to orient yourself, where is the appendix and where are you likely to see it. So everybody knows, I think, that is in the right iliac region. This is an enlarged view of the same thing, showing you that this is the ascending colon. This was this whole organ here was the cecum, and it's not smooth outlined, it's been disturbed, right? Ignore this for the time being, but just see the appendix, how it looks and how it is oriented in this particular cadaver, associated with the beginning of the ascendant colon, alright, and associated with other structures, vascular structures, nervous structures, and all, which we will see. We will ignore them, other things for the time being, and only look at the appendix as an outgrowth from the large intestine in the retroperitoneal part of the digestive tract. This is the one. Okay, this is a gloved finger of the operator, and this is the tip of the appendix, and it's going back somewhere till there. Okay, that we don't see. But what we are pointing out here is these yellow things are the appendices epiploicae, and if you find the tinea, we have actually, he's holding on to a band of muscle, this bit. But if you find any one of the 3 tinea, there's supposed to be 3 tinea coli, longitudinal bands of muscle. I think Dr. Srinivas Reddy would have shown you in large intestine. So if you take any one tinea and trace it downward to the cecum, it will come to the root of the appendix. In fact, all 3 tinea, posteromedial, posterolateral, anterior, all of them will come down and meet and continue as a continuous longitudinal coat on the appendix. We saw this in histology, but it has a continuous muscularis externa longitudinal coat. So all of them meet at the base of the appendix, and they cover the whole appendix as one longitudinal muscle sheath. So that whether it's a muscle sheath or not very clear when you look at it, because there's already a serosa covering it. There is a layer of peritoneum. If you were to peel it off, you would see longitudinally arranged muscle fibers. If you peel that off, you'll see circularly arranged muscle fibers. If you peel that off, then you come to the submucosa and mucosa. But don't worry about that. In gross anatomy, how to find the appendix is because it is hidden. It is posteromedial. You can catch hold of any one of the 3 tinea coli of the ascending colon and trace it down, or of the cecum, whichever you can find, and trace it down to the base of the appendix. All 3 will meet at the base of the appendix. So this is the view I wanted you to see. When you're standing on the side of the cadaver, this is the head end. This side, left is the head end, right is the foot end, and this is the ascending colon. You'll be seeing in the right lumbar region, right, and also right hypochondriac region, and here it will turn and become the transverse colon, and these are the midline structures, the inferior vena cava. Saying this is the right common iliac artery, and it will divide further. These are descending structures which are crossing the right common iliac and the beginning of the internal iliac arteries. You ignore that for the time being. From the lateral view, the appendix has to be pulled up to be able to show its entire length, otherwise it is tucked in there posteromedially, related to the beginning of the large intestine, and from here onwards all of this is the cecum. So if you pull it a little laterally, you will see there is a little bit of tissue attaching it, is coming out as a semi-transparent shiny sleeve of peritoneum, which is called the mesoappendix. Now, it may extend right up to almost to the tip, or it may be a short mesoappendix, not going the entire length. It depends on the length of the appendix, it depends on its orientation, it's variable in people, but there is always a mesoappendix attached at the termination of the ileum, which is not clear in this diagram. This is all colon, but there is a termination of the ileum. I'm not sure if this is it. Not clear, but there is a mesoappendix, and it's important because it is the mesentery which is now here what this is a different cadaver done by a different person, again Dr. Akram Jafar. The previous one, these were dissections, I think madam's name is Sankirtana or something like that. There is a dissection available on YouTube, you can please look at it. And so this is a different cadaver and a different time and different type of appendix and orientation. What Dr. Akram has done is done several cadavers to show you different positions of the appendix. In this case, what he did is he took the cecum and turned it backward to show you that this one's appendix is here. It's retrocecal in position, right? And when you pull the appendix away, this whole thing is appendix. When you pull the appendix away, you see that there is a mesoappendix attaching it to the organ. Now in this case it seems to be related to the cecum itself. Usually the mesoappendix is better related or clearly seen with the small intestine, with the termination of the ileum. Not in this case, but anyway, the idea is to show you that the length, the orientation and the relationship with the mesoappendix are all variable in different people. But the common fact is that you take the tinea and they will all lead down to the base of the appendix. Now when you do dissection in that mesoappendix, you can identify the appendicular vessels, not only the artery but the vein also. So you have the appendicular artery, which is a branch of the ileocolic artery, which belongs to the superior mesenteric arterial system. And this artery becomes very important to identify, because if you're going to be doing any surgery in this area, you might want to ligate the artery so that it won't bleed into your field of surgery. If you're going to release the appendix and tie it and remove it because it's inflamed or it's got a tumor or for whatever reason, you must close off its blood supply. So identification of the vessels within the mesentery of that organ, of any loop of bowel for that matter, is extremely important, and you must remember the appendicular artery position and where it's coming from and be able to isolate it during surgery. That is why you will be asked this even in anatomy. If your dissection specimen is cecum with appendix, then these questions will come. What are the contents of the mesoappendix? So apart from the appendicular artery and the appendicular vein, what else will you expect? Lymphatics, which will go back to superior mesenteric lymph nodes but via the ileocolic nodes. And you will expect nerve supply, from which will carry, sympathetics will carry pain, parasympathetics will carry the vagus nerve radicals for distribution, for maintaining the peristalsis, and these will come again within the mesoappendix. So all the supplies have to come within that double sheet of peritoneum, which is suspending the appendix from the ileocecal junction as an extension of the last bit, edge bit of the mesentery which suspends the small intestine. So this is just to show you that if you throw everything out and you see, then that if you trace the aorta upwards, you'll see that it gives off a superior mesenteric artery. This is giving the right colic vessels. Then this one is the ileocolic, which will give a lot of ileal vessels, and then it will go down and it will terminate as a ileocolic artery, of which almost the last branch is the appendicular artery. So okay. Now again, variables or variations in the position of the appendix. Now this is a cecum. This is clearly seen, big one, big bluish purple cecum, and you're seeing there is a finger leg projection which is going almost downwards. It's 5 o'clock or 6 o'clock. And if it's long, it will be actually peeping into the pelvis, in which case it will get related to the right side pelvic structures. In the female, the right fallopian tube and uterus and ovarian fossa are pretty close by. If it's a normal appendix, it doesn't matter. But if it's an inflamed appendix which is pelvic in position and long enough to go over the pelvic rim, it can cause an irritating effect on the female fallopian tube or the ovary, the reproductive internal organs. In both genders, it can irritate the right ureter because that also goes over the pelvic rim to enter into the urinary bladder. So a pelvic position of appendix is important. It may be only revealed by the symptoms of the related organs on the posterior abdominal wall. Similarly, this is another cadaver. So this is a cecum, and this is an instrument holding on to this structure, right? So this is a retrocecal appendix. So they basically had to turn the appendix to see that they had to turn the cecum, move it laterally like that to be able to see the retrocecal appendix. I also showed you the previous example. So the structures which will be related behind the cecum are the ones which will be important, and though there are other things, there are gonadal vessels and so on here, the main thing on which a retrocecal appendix will lie is the psoas major, the right psoas major. So if there is an inflammation and it is touching on the psoas fascia, it can irritate the psoas fascia and cause a reflex spasm of the psoas. So those symptoms will be referable to the right lower limb. Though it is a completely visceral problem, the responses or the referred symptomatology can come because of the psoas major in relation to a retrocecal position. If it's a prececal, more superficial position, then it does not impinge on the posterior body wall structures, definitely not on the muscles, but only in some positions that we correlate with, oh, this could be a right iliac fossa problem, which is giving rise to a psoas symptom. Otherwise, there is no reason for this person to have a lower limb issue. Now, psoas, is a flexor of the hip joint. I hope you remember. So the patient to protect the psoas may keep the right limb in a slightly flexed position, may have a kind of a abnormal posture, or when you're examining the abdomen, they would prefer to keep the limbs a little flexed because that is a more comfortable position. Because if you put the right hip in full extension, that it gets irritated more, the pain increases. So these are the clues which we have, and we derive information from those clues because we remember the relations of the structures in their many variables within the pelvic and abdominal cavities. So remember, the retrocecal has this. Now this one way of examining is to examine in situ. So far all the images we saw were where the cecum, appendix, terminal ileum, whatever, are still inside the body. But when you have it in an exam, you might have it out in a tray where you'd have the cecum, the terminal ileum, and the attached appendix taken out as a separate piece, washed and kept in a tray as a major discussion for you. So if it is there, then you can be asked questions on the ileum, on the cecum, and on the appendix, and particularly a lot of applied anatomy and everything about its supplies, and we can ask you development, we can ask you histology, anything. So you have to be prepared for all levels of questioning when this comes as a major dissection for you. So these are two specimens, two different ones. In this one, you can see the cecum, they've actually slit it, they've cut it, and you can see the appendix attached, and this is the terminal part of the ileum. The other one, it's an open wall, but they're showing you that the inside, this is the inside actually, this is the outside, and this is the inside, this is a cut, not fully opened out, just to show you the thin cecal wall, which is like a sac and bulbous, and does not show very clear tinea, which is why we depend on ascending colon to find the tinea which will come to the appendix. In this particular specimen, we can't even see the appendix clearly. We are seeing the ileum and we are seeing the cecum, and the reason we opened it is because we will give you a specimen in which you should be able to identify the internal structures of the cecum also. So this is the internal mucosa of the cecum, and that terminal ileum bit has opened it in the form of a two-lipped ileocecal orifice. So it is a stretched out piece. It's not round, but it is stretched out, two lips stretched like that, and that is the ileocecal orifice, a very clear and easy to identify. The appendicular orifice, so ileocecal orifice, I'm sorry, this is a little out of focus. I took this as a screenshot from some other video just to show you that the way in which it can look will be slightly different, but it's easy to identify. There's no big problem about it. The ileum will be projecting into, can you see it is projecting? It's projecting into the lumen like this, and therefore you are able to see lips. So that will be covered up with mucosa, and it functions as a valve, letting in small quantities of ileal contents into the cecum with peristaltic waves. So it doesn't dump everything at once, and that is all under autonomous control, that is parasympathetic mediated. Then, if you can make out, there is another orifice here, but we are not sure. But here, going back to the previous specimen, this was a lip-like ileocecal valve. The appendicular orifice is a rounder one, but 2 to 3 centimeters inferomedial to it. So the appendicular orifice is a smaller one, and it can be traced into, or it can be, I don't know if you can make out this side. This is the cecum, this is the ileocecal orifice, and this is the appendicular orifice. I'm sorry, it's a poor picture. We'll ignore this for the time being. We'll just go back. So the appendicular orifice is a small, round, smaller, much smaller and rounder one, close to the ileocecal orifice. Can you see the mucosa of the cecum is thrown off into folds, kind of horizontal folds. So that is the inner layer. The outside of the cecum will be smooth and covered with peritoneum. Okay, so that's it. These are the specimens you will have, and this much you have to bare minimum answer. But everything else about the appendix, what are its positions, what is its applied anatomy, maybe it's a little bit of about its embryology, a little bit of what is its possible function, why do we call it vestigial, what is its histology, why is it, how is it different from other parts of the colon, anything can be asked in the Bible. Then they will bring you back to body wall. Even if the specimen is in a tray, they will ask you what is McBurney's point. So I am not going to repeat it. If you don't know it already, you will now revise. What is McBurney's point? It is somewhere on the anterior abdominal wall, somewhere on the skin of the right iliac region, right? So there you will make a skin incision at McBurney's point. 2, because that is always the place where the root, the base of the appendix can be found, always deep to the McBurney's point. The tip of the appendix could be anywhere, and we are not going to search for it. We are going to search for the base first, so that then we can grab hold of it. So a small skin incision, you have a draped abdominal wall. The green is the surgical drapes. It's a surgeon putting in a skin incision. Then I'm sorry, because they are putting in the fingers are holding the instrument and the mop. So a gridiron incision is, you have the external oblique and you have the internal oblique, and we separate the two to give you a diamond shaped, or we do a cross shaped incision depending on how tight the muscle is. Usually we just separate the fibers, we don't cut them, and the external oblique aponeurosis is cut in a cross, and inside of that the muscle is just separated. The longitudinal fibers of external and internal oblique are separated. Then you get the transversalis fascia, and deep to that you will get the peritoneum. So we get all the layers out of the way, and we put this steel instrument is called a retractor. Put it, and you move your incision apart, you stretch it apart a little bit, and you get this glistening pink reddish membrane, which is the peritoneum, which is deep to the entire muscle layer. And you pull up that peritoneum and you give an incision in it. Now you are entering into the peritoneal cavity. So once you are entered into the peritoneal cavity, at that point on the right iliac fossa, you are right on top of the loops of intestine covering the cecum. So you have to get the loop of intestine out of the way, not pull it out, but push it out of the way. Pull on the cecum and be able to find the appendix. So I'm sorry, this is not exactly very well focused, but okay, the instrument is trying to hold the cecum and pull it out of that small incision. We have a small 5 centimeter, 3 centimeter, 5 centimeter incision, and out of that you're pulling the cecum, and when the cecum comes out, you will follow these tinea and come to the base of the appendix. Not very clearly see, but basically you will, along with the cecum will come the appendix. See the difference. It's going to be red and shiny and moist, wet, and the appendix will be a slightly how should we say, a little more solid, firm looking item attached on the cecum somewhere. So if you pull out a good part of the cecum, the base of the appendix will come out with it. We are a little careful because the reason we're doing the whole operation is because it's inflamed. So if you catch hold of the appendix very tightly, very without gentleness and without care to see what the condition of the appendix is, we can actually rupture it or puncture it or cause a contusion on it. So we are very careful when we are handling the viscera. We handle the cecum. The cecum can take a little bit of trauma. So we have specific instruments which have a soft grip on these intestinal loops. So you identify and deliver the appendix, cecum, and I don't know what TE is. No idea. Must be tinea. Must be with the tinea, and you're pulling it out. So this is the base, and this is somewhere here is the tip. Once you get it out, then you have to do. In this case, the appendix is looking reasonably healthy to me, but here we don't know. Here there may be a pus point. Not very clear. This was again a screenshot of a moving film, which was far away from the camera. So they did a zoom, and they once you do that, you lose definition, you lose sharpness. So the point is that is all the space and time available to us when we're dealing with a live specimen. Very little time because the patient is under anesthesia. Very little space, and your anatomy has to be perfect for you to be able to find the right thing on time and to do the next thing. So I don't have the next steps. It's not necessary for you, but basically we will clamp the base. We will identify the appendicular artery. So this is the cecum has come out. It's come out of that little aperture. It's soft and it's very pliable, so it comes out. And then you pull the appendix out, stretch the mesoappendix, and you find the artery inside it. So you clamp the artery, divide it, and then tie both the ends of the appendicular artery so that it will not bleed. Then after that, after we secure that it is a bloodless field, then we take the appendix itself, and at this place we put two catgut ties, then we divide it in between and deliver the whole appendix with appendicular or whatever is left of the mesoappendix, remove it and take it out into a tray. Then your artery is sutured, your root of the appendix is sutured tight, and it is allowed to be dropped back into the peritoneum. Then we do a peritoneal toilet. We wash it with saline or some normal fluid, isotonic with the peritoneal fluid, and so that if there are any little bits of pus cells or any bacteria, any inflammatory, any infectious things which may have spilt out during your surgery, they will also get washed out. And then we close the abdominal wall in its layers. So you'll close the peritoneum separately, you close the muscular aponeurosis layer separately, and then you will suture the skin on top. This is how a classic appendicectomy used to be done. But nowadays they do what is called a laparoscopic appendicectomy. So your dissector has some nice pictures. Your Atlas also hopefully has some nice pictures. On the web there are lots of good pictures of laparoscopic appendicectomy. So homework is take a look at that, but that's not going to be asked. Maybe if you're answering very well, your anatomy professor examiner may say, okay, suppose your patient has appendicitis and you want to do a laparoscopic approach, where will you put in the aperture? Will you put it at McBurney's, or would you like to go in through somewhere else which will give you better visualization? So that is homework. In this era of minimally invasive surgery, if there is a laparoscopic approach to intra-abdominal contents, luckily for us, appendix is intraperitoneal. So in one sense, it's a happy situation because it's easy to approach surgically. If you don't want to give a 5 centimeter incision and do all this grid iron and all that, then where would you put it in, and what would you do? Okay, look for it, and then if there are any doubts, I'll answer them. Once you come back, we will do a quick revision with the specimens in a tray, but you must revise all this and have it fresh in your mind when you come for revision. So in my next class, I think I'm doing urinary bladder, but in between we'll be catching up with the remaining organs also. So I'll see you as per the schedule. I'll see you again. Thanks.